who have joined. You should see in this Zoom app, I'm sure many of you have used Zoom amidst our pandemic, or other platforms for that matter. But just a review that there is a Q&A feature. We are going to have some time for questions and comments at the end of this presentation. If you do have specific questions as I'm speaking and presenting some of the slides and information we're going to talk about today, please feel free to use that feature. Also feel free to indicate any technical difficulties or challenges that you're running into. Some participants may hear my dog. I'm sure many of us are working from home or have kids or pets at home during this time. So we may hear him join in at times today. All right, so I'm going to get started. And again, for those who have joined, feel free to use the Q&A feature to ask questions or comments. I will address any questions or comments that come up as we go through this information at the end. We'll definitely have time for questions and comments. So first, I want to introduce myself and welcome you all this morning to this webinar entitled Early Signs of Autism Spectrum Disorders in Toddlers and Preschoolers. I want to introduce myself and tell you a little bit about my experience, specialization. So I am a pediatric neuropsychologist at NESCA in Newton, and I specialize in two main areas. One of those areas is assessing what we're talking about today, which is the early signs and symptoms in autism spectrum disorder. And I am going to mute myself for 1 minute. And sorry, guys, 1 second. Thank you all for your patience with that. Again, I have a dog at home who needed to be put in another room, so I appreciate your flexibility. Anyways, so I am a pediatric neuropsychologist at NESCA. I specialize in neuropsychological evaluations and assessment for kids as early as 1, 2, which is why we're talking about this topic today, focus on toddlers and preschoolers. I also have experience assessing kids into young adulthood who may present with an autism spectrum disorder diagnosis. I also see many kids and teenagers who have unique learning styles, who may have a diagnosis of autism or not. You know, neurodiverse learners that we have, and getting a sense of what kids' strengths and what their weaknesses may be for learning or social skills or emotional skills. Outside of kind of this early diagnosis and early intervention approach to diagnosing autism, my history and background is actually as a family therapist and working primarily in intervention with families and kids, both in kind of high risk moments in life, so during hospitalizations or residential treatment. So I also see a number of kids, teens, and sometimes young adults who present with more kind of high-risk behaviors associated with depression, anxiety, trauma, attachment-related issues. And because of this kind of dual interest and specialization in autism, as well as psychiatric functioning and emotional functioning, I see a number of kids with autism spectrum disorder who also have co-occurring challenges with depression, anxiety, OCD, or who may experience trauma or really difficult experiences and have impact on their life. And so today, the goal is to describe and provide some information for educators, as well as parents, clinicians, whether that be, an early intervention provider or educators who perhaps teach in preschools or at the elementary, middle school level, even around some of the early signs of autism spectrum disorder in toddlers and preschoolers. All right. So, we are going to talk about today some of the red flags or potential signs and symptoms that we see in really little kids. So that is the focus of our topic today. So toddlers and preschoolers, and a discussion of why diagnosis is important during this stage in development. We'll also spend some time talking about kind of our gold standard measures and ways that we assess autism spectrum disorder, particularly in toddlers and preschoolers, with a discussion of the diagnosis and the treatment implications, particularly now, both during the coronavirus pandemic, remote learning, and what that looks like kind of currently, both kind of locally and kind of nationally across the country, and what that looks like. And some considerations for intervention as well. We'll end with a Q&A, as I indicated at the beginning, to definitely have some time for participants to ask questions. All right. So, I'm sure we have some members of the audience who are very kind of aware or work very frequently with kids who may have a diagnosis of autism spectrum disorder. I did want to provide some overview of what the criteria for autism spectrum disorder is based on our current manual for diagnosis, the DSM-5, as there have been some updates over the years that we have been using for some time in terms of how we understand autism spectrum disorder as a wide spectrum of strengths, a wide spectrum of challenges. There's definitely a saying in the field that you meet one child who has autism spectrum disorder or an autism spectrum disorder, you've met one child who has an autism spectrum disorder. And I think that's very true. We know that there's high variation and variability in what autism spectrum disorder looks like in kids and teenagers for that matter. There are two main domains of functioning that guide us when we're looking at red flags, particularly in toddlers and preschoolers. Those two domains are deficits or challenges in social communication and social interaction across multiple contexts. So not just at home, but on the playground, at daycare, at school, as well as the second domain, restricted, repetitive patterns of behavior, interests, or activities. And we'll talk more about some of the symptoms and observable behaviors that are within that domain of challenge that we want to assess and evaluate for kids. Also importantly, this is a diagnosis that is starting at a brain-based level, meaning during the early developmental period, and we do have some growing genetic research that there is genetic loading and there are genetic factors in terms of differences in brain development for kids who have diagnoses of autism spectrum disorder. So that means that we would see symptoms appear during the early developmental period, which is generally between the areas of 0 and 3. We don't have there's no research to say that at 18 months, you're going to see, a spectrum of red flags for autism spectrum disorder. There are, some infants who may show some signs of ASD the first few months of life. There are also infants who may not show any symptoms or red flags until 18 to 24 months of age. There might also be toddlers who are gaining skills, kind of typically are what we would expect in terms of our milestones, and then there's a loss of skills or regression. That can also be a sign or related to autism spectrum disorder. There is some research from the CDC that about 1/3 to a half of parents notice a problem or have a concern about some of these red flags that we're going to talk about before the age of 1. So your first birthday, around that period of time, though that is definitely not pervasive. And I definitely see a number of families where there are very little concerns or challenges reported until 2.5, 3, sometimes later, sometimes 4 or 5. All right. Before we jump into early diagnosis and red flags, I also wanted to include a slide about neurodiversity. Neurodiversity is an important movement and understanding within autism spectrum disorder research, as well as organizations that are designed to support kids and teens and adults with autism spectrum disorder in really promoting a strength-based understanding of the diagnosis. So, in the previous slide, I had talked about the DSM-5 criteria for autism. I also, in working particularly with little kids around this early diagnosis timeframe that we're talking about today, really emphasizing the strengths and the neurodiverse strengths that we see in kids with autism. And neurodiversity is the idea that neurological differences like autism, like dyslexia, ADHD, are the result of natural variations in our genome or in brain-based differences. And, I think about it and I talk to families a lot about a different way or a way of learning, a way of thinking, a way of interacting with the world that, like all of us, present some challenges at times, but also evident strengths. I work with a number of kids with autism spectrum disorder that are particularly adept and gifted at, really getting into their interests and showing their passions and doing great things with those passions. And I think even at a very young age, understandably, seeking a diagnosis and seeking evaluation for young kids can be, fear-inducing or stressful for parents, understandably. And I think bringing that lens of neurodiversity is so important in supporting families through the diagnosis, through what does this mean, what do we do about it, and what are my child's strengths. All right, so before we jump into red flags, I want to start really whole picture of why do we care about early diagnosis of autism spectrum disorder, particularly in this, critical age range around your first birthday. Also, thinking of toddlers and preschoolers, kind of pre-elementary school. Why would we care about an early diagnosis at this stage? We have research, we have information, both in the US and internationally, that early diagnosis is important because it propels children on positive trajectories. Inherently, there's more time, more opportunity for growth or development in skills or challenges that are observed. We know that toddler brains and kid brains, for that matter, are very, very plastic. It's very different when I'm talking about how do we help a child develop their joint attention skills or using their eye contact socially with other people when you're 3 or when you're 4 even, compared to if you were 25 coming into my office. That'd be a very different period in a person's life, based on how plastic their brain is and what the opportunity is for growth in that specific skill. As a clinician who, as I mentioned at the beginning, has tracked kids both from this early age, 2 or 3 years old, all the way up to, young adulthood, right, 20, 25, we know that when we see kids and teenagers who might receive a late diagnosis of autism, or who may be diagnosed in teenage years, young adulthood, there is a higher likelihood of having comorbid conditions. So things like anxiety, depression, OCD, as I mentioned prior. And we know there's more time for there to be inherent difficult experiences, bullying, school stress, trauma, relationship disruption. And so early diagnosis is really important because we are catching kids before we in some ways can throw in some additional hurdles or additional clouding to the diagnosis, which can make diagnosis at a later stage in some ways more complex, though it can still very much be done. And we have a lot of research on how to do that effectively, how to distinguish autism from other conditions, as well as diagnose autism underneath things such as anxiety and depression. It nevertheless is a confounding factor, and one of the reasons that I care about early diagnosis, particularly for this young age range. I will also say, as I mentioned prior, I started this work in intervention, so not in the assessment and the diagnostic kind of evaluation related to challenges or diagnoses for kids. But working with families and kids kind of in the trenches as a outpatient clinician or in a psychiatric facility. And, you know, when we think about young kids, particularly toddlers and preschoolers, you know, we know that your first relationships are really impactful and really matter. You know, whether that be, of course, your caregivers, your family, also, you know, early intervention providers, your daycare providers, your extended family, you know, your network of people. And we know that in treating and supporting kids who have autism spectrum disorders, that we can capitalize on these first relationships to, again, build skills. And especially when we're talking about one of the challenges, you know, the core challenges being around social interaction, social communication. We're starting from an earlier place to really intervene at a relational level to create change. So, you know, as I said, there's research on the positive impact of caregiver-child interactions. We see things such as improved language and self-regulatory skills in kids who receive earlier intervention and earlier dyadic or first relationship-based work and support. I also think about, you know, when we think about receiving a diagnosis, working with a clinician who provides a doctor, a you know, medical provider who provides a diagnosis. It's a good opportunity to start to build relationships with both clinicians, educators who may be a part of that child's life potentially for a while, or for, in some cases, for, you know, until they reach young adulthood or beyond. So I think for families receiving a diagnosis in these early stages or early parts of life for their kids can help families also connect with a clinician or provider who can be really the diagnostic navigator throughout a child's development as they progress through school, progress through different stages of development, etc. All right. Okay, so now on to these red flags that we want to talk about and have a discussion. I'm going to describe some of the kind of more you know, common red flags that we might see, you know, if we do a Google search. I'll also include you know, research-based red flags that perhaps are less well known, or you know, take some more kind of analysis of some of the recent literature that has emerged. We know very clearly that children who have family members who have pre-existing diagnoses of autism spectrum disorder are at an increased risk of having a diagnosis because of that brain-based genetic loading that we know is associated with differences in brain neurology associated with autism. Some toddlers and preschoolers show limited use of body language or gestures. Now, for a little person compared to me, where I'm using my hands to speak, for example, you know, these are gestures like pointing to things or showing something, you know, a toy that you're really excited about, and sharing eye contact with your caregiver or day school or your daycare provider or teacher, educator. You know, also, you know, clapping, you know, high-fiving related to, you know, certain things that are exciting or interesting for children. Related to that, you know, we have your body language, your gestures, and your eye contact, how you use eye contact to interact with the world around you. And that's one of the, you know, I think kind of important ways that we assess, or one of the pieces we assess, and some of the gold standard measures we'll talk about, is how do kids use their eye contact and their body language to communicate? We know that there are differences in language development for kids with autism spectrum disorders. These include at times having delayed language or being later to develop either single word or phrase speech or sentence speech. This can also include loss of language or vocabulary words suddenly, a regression of skills, as I mentioned earlier. There's also differences in pronoun use, like switching pronouns, saying, you know, you instead of I in a sentence. As well as sometimes referring, some kids with autism spectrum disorders like to refer themselves in third person, you know, Renee is doing this webinar. Renee likes talking, right, about this topic. Some children present with some differences, or kind of caregivers or educators might say, you know, something different or unusual about their voice tone or the volume or something. You know, it just seems a little different than what I'm used to hearing. Sometimes more of a robotic voice, for example. Inconsistent response to name. So calling your toddler or your preschooler's name, and you know, they don't respond, or they don't turn their head to look at you and see what you're looking at or why you're calling their name. Sticky attention is a term in the literature and a lot of providers who assess kids who have autism spectrum disorders that is different from that kind of distractible looking around the room. Wow, there's a butterfly. I love it. That's so exciting, right? Sticky attention is that hyper focus, getting really absorbed, really into something that you're doing, right? You know, you're building magnet tiles, you're building Legos, and you're really in the zone, and you're really looking at those objects closely and seeing how those work, seeing how those wheels work. That can be a red flag as well. Repetitive, obsessive, or routines in play, either alone, you know, the child just playing by themselves independently, or as well as, you know, this is actually something that I hear pretty frequently in my assessments, is asking that caregivers or other adults, educators, therapists, do certain routines in play. And if that adult does not do that routine, there might be distress, dissatisfaction, disengagement from play. That routinized play, both independently and with adults and sometimes peers, is also observable. Importantly, all these red flags that I'm talking about, we're going to move on to some others. Not all kids with autism spectrum disorders show all of these red flags, 1 or 2 of these red flags, 4 or 5 of these red flags. You know, this is a broad spectrum of potential red flags, which is why putting together the information and an assessment of what are a kid's skills in these red flags or domains of functioning to determine if a diagnosis is appropriate is so important. Other red flags include not playing pretend or social games by around 18 months. So these are your peekaboo games, patty cake, pretending to talk on the phone. Rigidity in play, I talked about kind of routinized play. Rigidity or inflexible play is, you know, being kind of stuck in how you're using toys or what you want other peers to do. And if a peer tries to integrate or come into what you're doing with your dollhouse, you know, you might have a child, or you observe a child who's very upset, who disengages again, who shows a lack of interest in that kind of more reciprocal peer-based play. Repeating words or echolalia, creating new words or phrases. Poor reaction to changes, transitions. These can be bigger transitions, you know, things like moving from one house to another. It can also be a bigger, you know, daily transition, like going from, you know, out your door at home into the car, or going from your car into the school or into daycare. It can also be small changes, right? Like you put your child's cup on the left side of their plate instead of the right side of their plate, and that becomes very distressing or impactful for them. Other red flags include motor behaviors. So things like hand flapping, spinning, rocking back and forth. Some kind of sensory motor behaviors that we would see in kids, and sometimes these stimming behaviors are often referred to in kids with autism spectrum disorder. Also sensory hyper and hyporeactivity. That is also an important more research-based part of the diagnosis that has become very prominent compared to past diagnostic understandings in 10, 15 years ago even. So these are things like crashing, sensitivity to loud noises, sensitivity to textures, some tenseness or discomfort with physical contact or hugs. It can also be, the opposite of being, very reactive and sensitive, and in fact, seeking, right? That crashing, licking objects, being a really intense burrower and kind of all over your caregiver, seeking that contact and that comfort. that can also be, a piece of the constellation that we want to look at and assess. So I include these red flags here on a different page because, I want to kind of emphasize and make the point, in our time today and talking about the assessment of autism spectrum disorder is that outside of the red flags that we've talked about, again, both the ones we've talked about and these specifically are developmentally appropriate. Some of them are very developmentally appropriate and at times observable and, typical for toddlers and preschoolers. These are ones that are particularly true that we see. These are things like poor proprioception or have regulating your body in space with other kids or other adults, being emotionally sensitive and vulnerable to temper tantrums. We can all understand a toddler or preschooler, yes, they're more vulnerable to being sensitive and a tantrumer, right? Many of them are very appropriately compared to, let's say maybe a high schooler, right? Also, some of those daily living skills that we want to assess that can be related and are associated with the diagnosis of autism, poor eating, sleeping, and toileting habits. You can have poor eating, sleeping, and toileting routine habits that are challenging, right? And you do not have a diagnosis of autism spectrum disorder. Similarly, headbanging or aggression or distractibility, high energy level, being impulsive, right? Toddlers and preschooler brains are all still growing. They're all still building skills, building their executive function skills that help with, your attention span and your self-regulation. So that's why it's so critical to have an evaluator that really can understand the developmental perspective of, what's typical, what is expected based on this child's age, and what's the intensity and the frequency of these behaviors that we're observing that may lend itself to being clinically significant. All right, so the American Association of Pediatrics releases, as we know, a number of safety recommendations or recommendations about treatment and medical care, prenatal care through toddlerhood and early childhood. The American Association recommends early screenings, and this is important, follow-up diagnostic assessments for autism spectrum disorder rather than the wait and see approach. So, in past years and even 20 years ago, although this is also true in some regard now, we have some understanding that, perhaps, we're seeing these things, but, they'll grow out of it. Let's just wait and see how he does. We're going to get him into this new program or we're going to get him into therapy and let's just see how he does, right? For autism spectrum disorder, we have identified, and the American Association of Pediatric has identified through research, that the wait and see approach is not helpful. And in fact, having screenings and early screenings, both in infancy and toddlerhood, and follow-up diagnostic assessments is kind of our gold standard care for this potential diagnosis because we want to start those interventions early, as we talked about. The National Research Council, which is another national endeavor and kind of research-based organization that produces guidelines on educating children with autism spectrum disorders. And they released, I believe the last update was 2001, so they may be releasing a more updated one in the coming years. They release a lot of information on what are best practices or standards of care for kids with autism. And in terms of receiving a diagnosis, the National Research Council creates guidelines around these three main kind of factors in CP1. One is that the assessment or the evaluation should evaluate multiple areas and multiple domains of functioning, particularly adaptive skills, which were those kind of, for example, real life daily skills we were talking about, like toileting, dressing. Also things like communication and social skills are also adaptive, of course, real life skills. And an appreciation that there is variation in ability and performance when it comes to assessing and looking at the results of assessments for autism spectrum disorder. Meaning, as we know that autism spectrum disorder is a spectrum, and you meet one child with autism, you meet one child with autism. And so appreciation that there is variability in what the data looks like and what a child's profile is, what their red flags are, what their areas of need are, as well as I mentioned, that developmental perspective. What's typical for a toddler socially and behaviorally versus what's typical for a middle schooler, and being able to assess that in the evaluation. So with that in mind, it makes sense that accurately diagnosing autism spectrum disorder is complex. It's not a yes, it's not a clear no, right? There's a lot of variation and differences in presentation, though we have ways of assessing those differences and ways of quantifying, which is why an assessment is important. You don't see a child and then see the next child and see the same strengths and the same challenges, particularly with autism spectrum disorder. So there's variable behaviors within the same person across contexts. So, sometimes I see kids who have really significant sensitivities, let's say when they're at school, but when they're in the community, they don't really care about the fire truck, for example, if they're sensitive to loud noises, right? But they do care about the bell when they're at school. And that can be typical. Also, as we talked about, symptoms and experiences can overlap with other diagnoses. Depression, trauma, ADHD. So, having a diagnosis to delineate what's what and where things come from is so critical. Diagnostic criteria leaves much to clinician discretion. There is, for some of my colleagues, and I think some clinicians in the field, there's sometimes a phrase of it's easier to rule in autism spectrum disorder than rule out autism spectrum disorder. And what I mean by that is if we think about, kids who have social skill challenges or difficulty with social skills, that could be because they don't have autism spectrum disorder and they're stressed, or they're going through an adjustment, or they're growing differently and they may have ADHD. They may, have a significant loss in their life, right? So at the surface, it can often look like a child might present with some of these red flags, which is why it's important to get an evaluation to determine if that actually is an accurate diagnosis or not. Another thing I will say is, something that's pretty frequent in my work when I assess toddlers particularly, is that, we've realized, and we've, in the field and I think awareness in the neurodiversity movement also have come to recognize that we see a lot of kids with autism, a lot of toddlers, also, of course, into young adulthood as well, that are very socially oriented, that seek interactions with others, kids, adults, and they still may have a diagnosis of autism spectrum disorder. So I always tell, when I'm working with a family or working with a school, or early intervention providers for that matter, is you might have a very socially motivated kid, and yet there's other concerns. Maybe it's the sensory sensitivities or play, how your child is playing, and it still makes sense to have a diagnosis, even if a child may have some strengths in social skills. Okay, so I also want to include this as well as we're talking about kind of the variations and differences in what autism spectrum disorder can look like, even in toddlers and young kids. This is from the CDC, and I really like this diagram. So it's available to look at, of course, and they have more information about the diagnosis of autism. If you look at these kind of purple dots of where, if we had a child come in and we say, okay, social interaction, for example, their purple dot lies right next to a variety of friendships. They have a ton of, friends at preschool. They have friends, at their playground or in the community. Communication, maybe the purple dot on their communication is closer to nonverbal. Maybe they're only using single words still, right? And that's impacting their ability to socialize with that strength that they have. We see other, these diagrams for behaviors, sensory sensitivities, motor functioning. And again, this is to show you that, every child I see might have a different map for this diagram, right? And still, those children will have a diagnosis of autism spectrum disorder to describe the constellation of challenges that demand intervention and growth. Okay, so as I mentioned, when we were talking about the American Association of Pediatrics, early screening, early diagnosis is better than the wait and see approach. One thing that is excellent and wonderful over, I would say over the past 25 years is that there's been a lot of research, a lot of pediatric-based kind of training and collaboration with individuals who specialize in the diagnosis of autism spectrum disorder in creating screening tools and measures for infants and toddlers who, continue to have regular pediatric checkups, let's say, right? And so it's likely that infants and toddlers have and their families have taken a screening measure with their pediatrician around things related to language or social skills. And screening measures are wonderful because we have research of, this many questions answered yes could indicate we got to look at this further. We got to evaluate this in more detail. At the same time, and I have had experiences where this is true, because autism spectrum disorder particularly is so diverse and so variable in its presentation, where, we have a toddler who might answer, kind of below threshold on these, parents' responses say, hey, this, we don't see a lot of signs and red flags, right? We might still see a few. And if there are a few, one or two, I always recommend that getting a follow-up assessment or more information is still warranted and helpful. And I include some of these questions to kind of show you some examples of why. Would rather be alone than with others. Is your child interested in other children? Can't get his mind off something once he starts thinking about it. Avoids eye contact or has unusual eye contact. Does your child like climbing on things? Does your child try to copy what you do? What's important is that we can see if we answered either yes or no to these questions, you might have a child who is very socially interested and socially motivated. So they wouldn't rather be alone than with others. And yet maybe they're really struggling with being flexible or managing, their emotions or using eye contact socially. And so it's very important to continue, of course, to engage with these screening measures and to use those as ways to really target and support families that need an evaluation. But I also offer some caution for families around, if you have some questions or you want more information or you say, yeah, 9 out of those 10 questions we're not concerned about, but that one we are, that can still mean that a diagnosis assessment or an assessment to evaluate diagnosis is still warranted. And this is I use this diagram pretty frequently. We have this nice, paintbrush with some colors, where you're painting. And, if you go to the doctor and you get tested and you say, okay, do I have strep throat or do I not have strep throat? Right? It's kind of very clear. Yes or no. Usually, there's always different, some variation in that. You're either in the red column or you're in the green column. And on the other side, we have the diagnosis of autism spectrum disorder, as well as other, learning challenges or learning differences, right? It's a little messier. And I would say that assessing social skill differences or challenges and emotional, sensitivity or self-regulation challenges in kids is a little messier. And that's why a formal assessment is so critical and important. Okay. So in terms of our gold standard measures for autism spectrum disorder, so, let's say that, a family does decide to pursue a more thorough evaluation for our youngsters. So what we're talking about today, kind of 0 to 4 or 5, it is usually an evaluation that has certain components around assessing social communication, play, behaviors, and these are some of the tools that we would use to assess those, as those are the main domains that we know is associated with the diagnosis of autism. Those 2 measures that are frequently used, though there's others that are research-based, are the ADOS-2 and the CARS-2. I am trained in both of these measures. I deliver or provide these assessments very frequently to both toddlers and preschoolers, but also older kids. The ADOS-2 is a semi-structured standardized measure of communication, social interaction, play, as well as restricted and repetitive behaviors. 12 months to adulthood is the age range. And the CARS is a rating scale that also involves direct observation of a child and review of history. And that rating scale is from the ages of 2 to adulthood. Those are our two, I would say, main gold standard measures that are used pretty frequently, both here in Massachusetts and pretty nationally as well. So thinking about evaluating autism spectrum disorder, of course, we have our gold standard measures, right, that involves direct observation. Importantly, you have to get a sense of what a child or who a child is outside of your test office or outside of your evaluation. So that's accomplished through, of course, caregiver report and collateral report, speaking with an early intervention therapist, a teacher, someone who knows this child very well in school or in a different context than home. Of course, direct observation that should be designed like the ADOS. I'll show you some pictures soon. That is a social world. It doesn't feel like you're sitting down to take a test. We wouldn't expect any toddler or preschooler to do that, right? So it has to be very developmentally appropriate and in some ways fun and interesting, right? Toys, play, to really get a sense of who this kid is socially and how they manage their behaviors with other people socially. Also importantly, in order to diagnose autism spectrum disorder, it's important for young kids, so again, pre-4, 5, to get an understanding of some baseline cognition or problem-solving skills, as well as those adaptive skills that we talked about prior. Those are things like, starting to dress, or starting to, walk, right? As to motor skills, right? Also things like toileting, as I mentioned, toilet training. It's important to get an assessment of those skills to see if there are other factors that could be influencing a child's functioning or skills, right? Cognition, what their cognitive level is, what their problem-solving skills are, or perhaps, in motor skills, for example, motor delays or developmental delays in motor functioning that could impact. So these are, some examples. This is a big bin that has all of the tools that you use with the ADOS to assess a toddler, preschooler, and older kids as well. So you can see there's a lot of toys, and all these toys are used specifically in an appropriate manner to elicit certain behaviors socially, in play, that are measured and evaluated by a trained evaluator to use these tools to do so. So, like we use IQ testing to measure a child's IQ, let's say in middle school, you use these toys to evaluate how a child plays or how a child interacts with other people, right? And we set, social scenarios like, having a child engage in peekaboo with their parent, requesting bubble play, using bubbles socially with the evaluator or, even their caregiver. I include this, it's an interesting study. So one of the skills, as I mentioned prior, that we're looking at in evaluating social communication, say using the ADOS, all those toys that I was just showing you, is joint attention or using our eye contact socially to share and show something of interest. And this was a study done on older individuals, actually, even though we have other studies that look at, of course, eye contact and how infants and toddlers use eye contact and where they look and what they're looking at. But I like this because it uses this diagram. This is an old movie, and we have viewers who were diagnosed with autism spectrum disorder and viewers who did not have a diagnosis of autism spectrum disorder. And the researchers measured where do people look who have autism spectrum disorder and where do people look who don't in this study specifically. And the yellow line you can see kind of creates this triangle. So there's this guy pointing to something on the wall, and we see that we're kind of looking at these both people and then looking at the object that they're sharing or talking about. And the individual with autism has differences in how they evaluate a social exchange. And the red line shows they looked at the object and spent some more time looking at what's on the wall, for example, or what are some nice details that they can see in this scene. And so, this is an example to show that, not only at a brain-based level, but in the ADOS or a type of evaluation that I am using to assess toddlers and preschoolers, we can see very early on how do toddlers and preschoolers use eye contact and gestures and their body and space to communicate socially. And we can quantify that and use that to create or use a diagnosis if it's appropriate to access intervention. All right, so a couple things about diagnosis during a pandemic. Definitely at this stage, and luckily we are making a lot of gains in how we're servicing and supporting kids with autism spectrum disorder during a pandemic. There's a number of, early on in the pandemic, there was a number of research endeavors and clinicians across the country who are working very hard to develop some more standardized methods of telehealth observation and assessment, which has been used actually prior to the pandemic in more rural communities in parts of the US that might not have access to an in-person clinic. So there are some assessments that are out there that are being used mostly I know some clinics in Boston were using, I believe, the tele-ASDPs, but mostly also on the West Coast, the BOSA was another evaluation. So these evaluations can be understood as kind of similar to the ADOS or the CARS, but conducted via telehealth. So in many ways, instructing a caregiver to play or interact with a child to elicit these behaviors that we want to observe to capture a possible diagnosis. Of course, amidst the pandemic, as a clinician who has been diagnosing kids with autism throughout the pandemic and supporting families as well with that diagnosis and what that means, is flexibility in how we gather our data. We're in a pandemic where families and kids many of them are more stressed and more anxious, which can really produce a lot of challenging behaviors for kids. And so asking families to provide like a home movie of what your child was like before the pandemic can be really critical to get a sense of baseline social skills and behaviors. And of course, prioritizing collateral report, right? So, and here, and what I'll talk about for the next one at NESCA, we have the opportunity of doing in-person assessment instead of telehealth observation in a safe and socially distanced manner, or in a two-office manner that does not allow contact, but allows direct observation and allows for kids and parents to take their masks off. So that, of course, is one way to assess and have direct observation in a safe manner. But I want to know what this kid is like outside of that interaction. And I also want to know what they're like outside of a pandemic. And that's where, I've spoken with their developmental therapist or ABA provider. They had a sense of, what are they like or who have they been before this pandemic or during, and what do they look like outside of it? Understandably, particularly during a pandemic and during a period of time where there is a need for more flexibility in how we assess autism, though still nested in the research-based methods that are appropriate to do so, it's critical to continue to access a trained expert who has experience using the ADOS, who has experience using telehealth, if that's the method that must be employed for the diagnosis, right? Critical. Okay, so to end and to get focused on our time for questions and comments, I'll say, I've talked about this in other lectures, both for older kids, as well as for different diagnoses and different neurodiverse ways of learning. It's never just about test scores. It's always about how this child is functioning with adults and other peers, right, and their community in the world outside of one's office. And for autism, scores on these measures, they are designed in the research to be tools that clinicians use. Scores do not diagnose. Trained experts and clinicians who understand autism spectrum disorders, including its strengths and the challenges associated with the diagnosis, do. Clinicians do the diagnosis. You always need collateral information, thus, as a result. It's never just about the test scores. All right, so lastly, I include some information about intervention, and I included this slide also, with providing some examples of what is also still accessible amidst the pandemic. A lot of the services here are available and accessible through telehealth methods, some in person as well. So of course, that includes in Massachusetts as well as other states, early intervention for specifically kids who are ages 0 to 3. Now, importantly, kids in Massachusetts can access early intervention without a diagnosis of autism. There may be, some developmental delays or some skills that, families or medical providers are worried about. There might be an issue at birth or challenge that has to be addressed. With the diagnosis of autism, should that be appropriate for a child, let's say who's 2 and they are enrolled in early intervention, receiving a diagnosis can guide some of those or help guide some of those services around like occupational therapy or speech and language, as well as some autism specialty service provider specialists that are assigned to work specifically with kids who have received a diagnosis from a provider. Similarly, for children, particularly under the age of 5, who are diagnosed with autism spectrum disorder, in-home applied behavior analysis therapy is a research-driven intervention that can be very critical. I work with a number of families who have benefited greatly with ABA in terms of kind of those daily routines and tantrum behaviors and toileting. That has been particularly useful and helpful, as well as other important aspects of functioning like communication and social skills. Other options for intervention include private speech and language therapy, accessible through insurance, OT or PT services. Once a child ages out of early intervention at the age of 3, a diagnosis of autism is an important kind of next step for receiving an eligibility evaluation for special education, which can then support a child in receiving services in school and outside of school or in preschool. Social groups, caregiver child dyadic interventions, as I mentioned at the very beginning of this lecture, intervening with first relationships, RDI, floor time, DIR models are helpful models to keep in mind for seeking some more dyadic and socially based interventions for kids. Social thinking, zones of regulation, as well as connecting with a network of social supports. That's something I definitely recognize as a clinician working with families, is being able to connect with, an ARC or an Autism Support Center or your local CPAC through your district special education advisory councils that help support have access to services and knowledge and information and resources. I will also say that lastly, the NRC that we talked about earlier in terms of research recommends that kids who do have diagnoses of autism spectrum disorders receive 20 to 25 hours a week of intervention. And that includes not just at home, or that includes also school, so participation in preschool and whatnot. So I will stop there and want to leave some time for questions, comments about today's information. I also am one of the lead clinicians at the Autism Spectrum Disorder Diagnostic Clinic at NESCA, which specializes in this particular age group that we're talking about today. So diagnosing and supporting kids, specifically toddlers and preschoolers, with access to a first diagnosis, particularly to guide services and guide access and provide access to services through insurance or through early intervention. So I'm happy, of course, to answer questions now, or I can also be reached by email if you have further questions or have questions about referring a family for this type of evaluation. I appreciate all your time this morning, especially for those of you who were here at the beginning when my dog was joining us for a few moments and barking. So I appreciate that. And I hope that the information today was useful and beneficial, especially if there are educators or parents who are, considering consultation or seeking a diagnosis evaluation. Okay. All right. So one of the questions, a very excellent question, is, I assume a child can have sensory issues but not be on the spectrum. Yes, very important question, and very true. Many, if not all of the red flags that actually all that were discussed at the beginning, especially around this toddler and preschool age range for red flags for autism. All of those things, including sensory, dysregulation or sensory sensitivity, or let's say even echolalia, repeating speech, that is a developmentally appropriate language development for kids. Those skills does not necessarily, or those challenges, let's say, or those observed behaviors do not necessarily mean that a child has autism. So in terms of sensory processing and sensory issues, 100% true that there are some kids who may have sensory processing difficulties or challenges and not have a diagnosis of autism spectrum disorder, do not have a constellation of symptoms that would suggest that. Nevertheless, I definitely see kids who have sensory processing needs that benefit, of course, from things like occupational therapy, sensory motor therapy, sensory diets, and whatnot. How many sessions does it take to collect information for diagnosis of autism spectrum disorder? So there's definitely variation in terms of how clinicians use their diagnostic plan for assessing autism spectrum disorder. For this age range, it also depends on, of course, the child, their developmental level, what aspects of functioning we should be assessing. If I was seeing a child who was, let's say, middle or high school compared to this age range, I would be wanting to better understand their cognition and their academic functioning, for example. For little kids and for an ASD diagnostic assessment, I and many clinicians have direct observation that might include 1 or 2 meetings in person with the child, depending on activity level, interest, how they're feeling, right? And then also collateral information and gathering of history. So that would usually include an hour intake, for example, or a meeting with caregivers. The direct test, the gold standard measures, 1 or 2 sessions, a phone call or a listening feedback from a daycare provider, early intervention provider, educator, therapist, either via phone, filling out certain questionnaires related to autism spectrum disorder or development, and then a feedback to describe the results, as well as a written report or summary of the findings and recommendations. I would say for the majority of assessments, there is usually at least 1 direct observation, sometimes 2, depending on the needs and the referral question. And for the CARS, does it include information from caregivers in addition to direct observation? Yes. So in terms of the CARS, there are 2 versions of the CARS, 2 researched versions. One is the CARS standard and one's the CARS high functioning version. One of those scales is designed for little kids, so generally below the age of 6, or for kids who might present with cognitive delays or lower cognitive functioning. That evaluation is purely based on one source of information. That's how the measure was created in the research. So that often includes filling out that questionnaire and that evaluation as an evaluator based on direct observation of the child in your office. Sometimes that is not the source that you use, and you actually use parent reports to complete the CARS ratings. Those questionnaires or ratings that are made, importantly, must be administered by an individual who has the possibility of providing an autism spectrum disorder diagnosis. So it is a different type of measure than, say, filling out a behavior rating scale. It's similar to the ADOS in that you should have training and expertise in using that measure. And the CARS high functioning version, which is again for older kids, that measure requires that you use two pieces of information, direct observation and another source, not just your own observation. So interactions with a caregiver or teacher for that matter. All right. We have one more. If you suspect, and then of course, feel free to email me with more questions. If you suspect your child has sensory processing issues, do you recommend that you only get an OT eval or a complete neuropsych OT eval? Good question. I would say that depends on age also. I think for a lot of little kids that I see, they may be, considering early intervention or an OT evaluation. And so I often see kids who have already had an OT evaluation and also consider either a neurodevelopmental or more focused diagnostic assessment. For little kids, I would say it's more common to kind of do a combination of both. And then in terms of kind of our older kids, I think that if there are questions around the source of kind of the sensory processing needs and whatnot, and other questions about social functioning, academics, education, attention span, then it makes sense to also consider a neuropsych for older kids. It really depends on whether you be an older kid or a toddler, kind of what your questions are. And, if you have broader concerns, if you have very specific concerns, I love working with the OTs that we have at NESCA. For example, they're a great team. And so they're my colleagues, and I respect and really appreciate all their analysis and understanding of sensory motor functioning and processing. And it's really invaluable to have that information and data, particularly for little kids, so these 0 to 5 year olds. So I hope that's helpful in answering that question. All right. Well, we are just about out of time today. I appreciate you all for coming, for asking very important questions. And again, I am available via email. If you're interested or have questions about the ESD Diagnostic Clinic, or other questions about OT, speech and language, feel free to reach out to me or our NESCA kind of referral line, and we can go from there. I'm also available to answer more questions about particularly this topic or anything we've talked about today if people have follow-up questions. So thank you all so much for your time. Have a great weekend.